I'm Steve Charles. I'm a vitreoretinal surgeon in Memphis, Tennessee. I've been involved with Orbis for 30 years and delighted to be able to present in this manner. I've made many Orbis strips, but this is an efficient method of communicating. As all of us know, diabetes is growing in frequency worldwide and prevalence worldwide. It's driven in part by changing diets around the world, and as well as lack of health care in some instances, and therefore the incidence of diabetic vitrectomy and diabetic retinopathy in general is growing. Anti-VEGF therapy has changed it somewhat, but it requires monthly injections. It's more effective than laser, as we know from the CRNet studies. That said, many patients, particularly in developing countries, are unable to have injections every month or have no access to preventative care and present later in the disease with either diabetic vitreous hemorrhage, as we'll discuss, or with the diabetic traction detachment. So let's begin by addressing the indications for vitrectomy. As I mentioned, there's several. Traction retinal detachment has been an indication for a long time. I've probably done more of these than anybody in the world, and it's been a big interest of mine for over 40 years. A big production is often made of patients that have a so-called combined rhegmatogenous traction detachment. These are not any more difficult. It just means you have to use gas or occasionally silicone oil, the gas being preferable unless they're very large breaks or multiple breaks. Extramacular traction detachments are often operated by people in the context of macular threatened. I believe this is a mistake. I published with Carl Flynn a paper well over 30 years ago showing the incidence of progression to involve the macula is only 25%, and you get good results if you operate when that happens. So operating on small traction detachments or even medium-sized that don't involve the macula is a mistake, and you subject these patients to unnecessary complications. I've heard the term intraretinal fibrosis. Never happens unless there's retinal necrosis, which is certainly not a part of diabetic retinopathy. Vitreomacular traction syndrome is something that we were largely unaware of until Hill L. Lewis brought it to our attention some years ago, and he referred to it as a taut posterior vitreous cortex, which is certainly the case. But the widespread adoption of OCT, ocular coherence tomography imaging, has radically changed our treatment of these patients because we're able to recognize VMT. For many years, instead of using focal laser for patients that have macular edema, particularly in Japan, and in other Asian countries, they use vitrectomy and laser first, vitrectomy in lieu of laser as the primary care. Why would vitrectomy alone help diabetic macular edema? Because it increases permanently the oxygen level in the back of the eye. When you remove the vitreous, you increase the viscosity 900-fold, and as Einar Stephenson has taught us, because of the fixed Starling principle, a greater amount of oxygen is allowed to diffuse into the vitreous cavity from areas that are rich in oxygenation to areas that are ischemic, so-called source and sink of this oxygen. So the macula obviously needs to be greater oxygenation, and it's so supplied. Nancy Hokamp was able to show that the partial pressure of oxygen in the vitreous cavity permanently increases by 12 millimeters of mercury after vitrectomy. And again, this is because the diffusion has nothing to do with the infusion fluid or ascorbate depletion. Ascorbate depletion is a result, not the cause. So in short, if there is demonstrable traction on the macula using OCT imaging, then vitrectomy and ILM peeling is appropriate. But doing vitrectomy and ILM peeling for diabetic macular edema without traction is inappropriate. These patients are better treated, as the CRNet has shown, using anti-VEGF compounds, typically on a monthly injection schedule. So here's a typical case with both traction and diabetic macular edema. In this case, the traction is modestly prominent, I would say. So clearly this patient needs anti-VEGF compounds, one in addition to probably vitrectomy. If you look at the submacular space, there's subretinal fluid there. Why would that be? Does that prove there's traction? No, it doesn't. It proves that the amount of leakage of the perifoveal capillary bed is so great that the RPE pump is overcome. Think uveal scleral outflow here, and the pump is simply incapable of keeping up. So when you have large amounts of paramacular capillary bed leakage. Often there'll be some subretinal fluid in the macula, and treatment with anti-VEGF compounds will address this. So let's look at some other cases and to see. Now here is a case that has some swelling due to leakage, as you see by these two spots on the right side of your picture, but clearly there's a sort of a plateau appearance to the macula. Yttria or acroplasm is known is, in my view, completely inappropriate to use in any of these cases or in any case, in my opinion. I've never once used yttria or acroplasm and intend never to use it. The complication rate is significant, and some of the complications based on probably SparkCan6, the interphotoreceptor matrix dissolution and damage to the ellipsoid layer of the photoreceptors is irreversible in some instances, and there's no known way to predict it, no known way to treat it. Some patients get serious fluid under the macula. So in short, don't use acroplasmin for any of these patients. But in a patient that has this configuration, vitrectomy and ILM peeling is appropriate. This is quite obvious here that there's a low-level traction detachment or advanced vitreomacular traction syndrome, whatever you want to call it. And in this case, because it's the vitreous surface and there's not any epiretinal membrane proliferation, ILM peeling will again work. I strongly urge the surgeons to not make an aggressive PVD in these instances, but to do ILM peeling first. Do a core vitrectomy, but don't grab the vitreous. Many people think there's a linear algorithm in vitrectomy. First you do a core vitrectomy, then you make a PVD, then you deal with the retinal surface. If you do that in patients that have vitreomacular adhesion, you can avulse the macula. That doesn't just happen because of the case. It happens because of bad surgical management. So in short, don't make forceful PVDs in diabetic traction attachment cases or in cases like the vitreomacular traction syndrome here. Please do not make an aggressive PVD. Yes, you must remove the posterior vitreous cortex, but do it in a controlled fashion with scissors if it's a traction attachment, or a controlled fashion with forceps ILM peeling if it's a vitreomacular traction syndrome case, not by pulling on the vitreous with a soft tip cannula with the risky fish strike phenomenon where you move the cannula from side to side. In macular hole cases, not part of this lecture, where you should make a so-called forceful PVD, you pull directly straight back from the disc, not side to side. Side to side motion puts shear force on the vitreous space, increasing the risk of peripheral retinal tears. So here's another case that has both leakage from diabetic macular edema as well as traction. If you look at the second slide, the traction is very, very obvious. And again, I do not recommend use of either pneumatic retinopexy, which is far better than acroplasmin, and would never recommend acroplasmin for a case like this. This case needs ILM peeling. What about vitreous hemorrhage indications? It's interesting, in the 44 years I've been doing vitrectomy and 42 years in practice, it's amazing to me how there's singularity around the question, how long should you wait in a vitreous hemorrhage? Well, this seemingly paramount question is overemphasized. There are many other considerations. For one, is it a thick, dense hemorrhage that's likely to take a long, long time to clear? That's different than a mild hemorrhage when you can even see the retina. Is there an underlying traction detachment based on ultrasound, in which case you must operate? Is there iris neovascularization, in which case you must do vitrectomy and PRP, as well as anti-VEGF therapy to prevent neovascular glaucoma? What's the vision in the other eye? What's the patient's general health? Are they on dialysis? Are they anticoagulated? I'm not concerned about anticoagulation. In my view, it doesn't. If it's patients are anticoagulated for any cataract or retinal procedure, their anticoagulation should be continued. I've published on this with Phil Rosenfeld. It's very, very important to continue their anticoagulation status to protect their life. That said, I've not seen a significant issue of interocular bleeding that was uncontrollable due to patients being anticoagulated. So let's again go through the list: cataract, glaucoma, medical status, the density of the hemorrhage, clearly the presence of iris neovascularization, traction attachment. All of these drive the decision, the clinical decision making, the judgment on whether to do vitrectomy for a vitreous hemorrhage. It's not just about how long it's been there. Very, very important to think in this manner. The crunch syndrome, or rapid fibrosis from injecting anti-VEGF compounds in people with fluoride neovascularization, has been massively overemphasized. First of all, it wasn't everybody that got an anti-VEGF compound. It was a small cohort of these 100 or so patients reported by Harry Flynn and others. Secondly, in my view, these patients were at risk of blindness from neovascularization of the iris in neovascular glaucoma, from retinal lenticular neovascularization, also called, which I first reported, also known as anterior hyaloidal fibrovascular proliferation, and from glial recurrence, which I first reported. So these patients had a bad prognosis. Regardless, you just change the nature of their complication. But in fact, I think it's very important for patients that have fluoride neovascularization to receive Avastin or another anti-VEGF agent approximately 3 to 7 days before vitrectomy, so you reduce the risk of bleeding. If you stay in that time window of 3 to 7 days, this rapid cicatricial fibrosis or crunch syndrome is highly unlikely to occur if it occurs at all. And it's very important in anybody that has active neovascularization before or noted during vitrectomy, they should get Avastin at the end of the case to prevent rebound. I believe it's Stanley Chang that first brought this to our attention, or possibly Bob Avery, but this is a very important thing to bear in mind, that you're removing any anti-VEGF compound you injected pre-op at the time of vitrectomy, not intentionally, but because you've, if you will, flushed out the vitreous. And so at the very end of the case, please inject an anti-VEGF compound. Again, very important. PHACO-VIT is massively overemphasized worldwide. In some instances, that's because you can charge for both procedures. In other instances, because people are comfortable with phaco, they like it, they've done a lot of them, and it is, in my opinion, adds complications to many, many cases. First of all, if you do not have nuclear sclerosis, you will not get it from vitrectomy. The idea that vitrectomy always causes cataract is complete and utter nonsense, repeated on the podium by vitreoretinal surgeons worldwide over and over and over again. It is a lie. It's not true. It never happened. I have hundreds and hundreds of patients that are 10, 20 years out from diabetic vitrectomy that have no nuclear sclerosis. What's the trick? They were 20 years old, 30 years old, and had no nuclear sclerosis when we started. On the other hand, if you have 1+ nuclear sclerosis, it will unequivocally progress. I've seen numerous patients that have had a PHACO-VIT, and the vitrectomy part, which was the reason to do the procedure, was poorly done because of complications with phaco. The pupil came down, couldn't see the periphery, put in iris hooks and pupil expanders. Now we got fibrin release in the anterior chamber and inflammation post-op. Now we got posterior synechia post-op. And in the developed world, patients demand emetropia. How do you, in a vitreous hemorrhage traction attachment case, figure out axial length accurately? How do you properly do Ks and As in patients like this and produce and use the proper algorithms? Are you able to do torics and get the axis of rotation properly? Absolutely a huge challenge, and that the vast majority of vitreoretinal surgeons are not up to this challenge. So I would strongly urge the listeners, focus on fixing the retina by doing proper vitreoretinal procedures, and don't jump into PHACO-VIT in case after case after case. And please don't do PHACO-VIT in patients that have a clear lens pre-op, because they're going to get a cataract. It's simply not true. If they have NS, you can certainly think about it. Now, if the patient's very, very ill and you're concerned, or you feel like transportation, logistics, they won't come back, maybe PHACO-VIT's appropriate, but put some emphasis into getting the refractive outcomes. Don't use an out-of-date single formula and A-scan axial lengths. If you can get an optical coherence axial length which measures from the pigment of flame, it's going to be more accurate, far more accurate in the presence of macular elevation. What about diabetic traction attachment? A pet interest of mine for many, many years. We hear people on the podium who are well-meaning say over and over again, oh, today's cutters are so good, they have higher cutting rates, true. They're small diameter, true. They allow safer removal, therefore you don't need scissors anymore. Completely fallacious. There's those same people, I promise you, when they do difficult tabletop traction attachments, one of two things happen. They either say, oh, this is inoperable, I can't do it, it's a tabletop, it's an end-stage disease, forget about it, or they make 400 retinal breaks and put oil in the eye. If you put oil in a diabetic, plan on having a poor outcome. Try to think of every possible way to not use oil in the diabetic. Why? Oil constrains VEGF. basic fibroblast growth factor, fibrin, fibronectin, and other cytokines and cellular elements, basically Mueller cell glial elements, confines them to the retinal surface, and because the retinal surface is waterproofed, if you will, by the silicone oil, you can't deliver anti-VEGF compounds to the retinal surface, only at the inferior equator where the oil is not in contact with the retina. So this notion that, oh, it's a bad case, I need oil, that's because you're not doing it right. So in short, learn to use scissors instead of saying it's a bad case, making forceful PVDs, making lots of retinal breaks, trying to do everything with a cutter, and then putting oil in. You must learn to use scissors for broad areas of adherence, or you're not going to be able to manage the more difficult cases in a safe manner. This is the most important single thing I could teach today in this diabetic traction attachment. You look at a case like this, if you try to do all this with the cutter, you might be lucky and not make a retinal break, but I doubt it. If you're able to use the scissors carefully, you're able to delaminate. Also remember, I'm the inventor of segmentation delamination. I don't bring that up to brag. I bring it up to make a point. Segmentation means to cut the membrane into pieces. So let's say simplistically to cut it up, to release tangential traction in the retina. And it works. And there are many, many cases where we still do segmentation only. And it's solved many, many diabetic traction attachment cases over the years. If you have broad area of adherence, you must use delamination, which allows you to sorry, I got a phone call, I had to hang it up, allows you to remove all the epiretinal membrane. Because we now have this capability with better cutters and better fluidics, as well as scissors to remove all epiretinal membrane, does not mean that epiretinal membrane is cancer, and if you remove all of it, it won't come back. Mockhammer had a singularity around the point that vitreous and membrane were kind of like cancer. If you got it all out, it wouldn't come back. And that is absolutely wrong. It's wrong in PBR. It's wrong in the diabetic traction attachments. The reality is that PBR, as well as glial proliferation on the retinal surface, the diabetic traction attachment, is much like a keloid. If you will, nature put it there for a reason. And if you remove it, there's a propensity for it to come back. And so the idea that removal of all of it is the goal, that's wrong too. So even though I invented delamination, which has better outcomes, there's less glial recurrence for reasons I'll discuss in a moment, that doesn't mean that I'm an advocate of removing every bit of epiretinal membrane in every case. So let's discuss a little bit what I'm getting at here. If you leave islands of epiretinal membrane, so-called epicenters, the cut edges of these are vascular and bleed. And it's very common to see a dumbbell-shaped glial reproliferation where fibrin joins if you will, the two cut edges. So it bleeds, a fibrin bridge is formed, glial cells derived from Mueller cells proliferate across that bridge, and now you've got a glial recurrence. Mockhammer and Michaels and others denied the existence of this until at meetings I showed them their own post-op pictures where they were different at a month than they were in 6 months, demonstrating this phenomenon of glial recurrence. It's real, and we need to do everything we can to avoid inflammation, to avoid bleeding, to avoid excessive retinopathy and laser, all of which stimulate this keloid-like glial recurrence process. So again, here you see in the lower right-hand corner the OCT showing traction elevation of the retina, and you can see it on the infratemporal and a smaller area in the supratemporal vessels. If it's present nasally, be careful. Don't remove everything nasal. It's not going to affect central vision. It does secrete VEGF when the retina is elevated, and let's talk about that for a moment. The retina the inner part of the retina is oxygenated, of course, by the central retinal artery and its branches and capillary beds, whereas the outer retina is oxygenated by the choroid capillaris, more so in the periphery. But what happens if you have elevated retina? Now the choroid capillaris has to provide all the oxygen. It is the external limiting membrane is not really a membrane, and it's not a barrier to oxygen diffusion. It's all about oxygen, partial pressures of oxygen and oxygen tension gradients. And so if you elevate ischemic retina from the choroid capillaris, it secretes more VEGF. So iris NV, post-diabetic vitrectomy, when you can't see in the eye, is the retinal detachment until proven otherwise. And we saw this a lot in the early years of vitrectomy with inadequate equipment and more common postoperative detachments. So this patient has fluoride neovascularization. If this wasn't treated with pre-op anti-VEGF compounds, you would have massive bleeding before and after surgery. So this case should be treated with Avastin pre-op and vitrectomy performed within 3 to 7 days. The same thing here, that's somewhat cicatricial. You can see a little undercutting of the macula, lamellar macular hole. I have sort of underestimated the need to do ILM peeling in these cases. You can't always peel over the arcades. In fact, you infrequently can because of strong glial adherence. But by peeling the macula, you can get ILM off the macula. You can get rid of macular folds, even these traction attachment cases. And I've only begun to do that in recent years. The notion of core vitrectomy is simply a mistaken notion in the context of diabetic traction attachments. So what should we think about? Cortex has multiple layers. Think cerebral cortex, adrenal cortex, renal cortex, the cortex of the lung, multiple layers. So the term posterior highlight face is a misnomer. It's not a face. It has multiple layers. And so why is core vitrectomy a misnomer? When you have traction, vitreous collagen fibers are only 2% by weight or by volume of the vitreous cavity, and all of the collagen is condensed basically into a sheet. So you never see proliferation within the vitreous. Vitreous bands never happen unless a missile went through the eye, some trauma or some parasite that caused necrosis. But with diabetes, there's never intravitreal fibrosis, never happened. It's always at the outer surface of this posterior vitreous cortex. So when it's pulling on the retina, as graphically depicted in this illustration, you must truncate, as I call it, this conical shape. If the posterior aspect of the cone is very broad, that indicates broad areas of traction. If it's a tight conical element, it's often inserted on the optic nerve head and sometimes mistaken for total retinal detachment on ultrasound. So again, if it's very a tight, a small apex in the back, usually it's on the optic nerve, occasionally on the supratemporal and infratemporal vessels. So even in an opaque media eye, you can look at the shape of this posterior vitreous cortex, even if it's opaque, and kind of judge what's going on, which will help correlate with your imaging, your ultrasonic imaging information. Pulling on this to make a PVD is the biggest mistake that's commonly made in vitrectomy. Simply do not do this. You don't just make breaks at the posterior edge of, the outer edge of the traction attachment posteriorly. You also make breaks periphery. Why would that be? Well, vitreous is permanently adherent to the retina at the vitreous base, permanently adherent, and you'll never ever peel vitreous off the pre-equatorial retina. It's permanently adherent. And the tensile strength of peripheral retina, as Mockamer showed, is 1/100th that of the central retina. So by pulling on this, not only do you risk posterior breaks, but you risk peripheral breaks that may be out of your view in a patient with hemorrhage in the periphery. So it's this notion that the algorithm is first do a core, there is no core, then second make a PVD, making a PVD is dangerous. Please don't do that. Take the cutter to the vitreous. So I've heard people use this ridiculous term, flow efficiency. Oh, 23 gauge has more flow efficiency than 25 or 27. There is no such term as flow efficiency. There's flow or efficiency. Efficiency is the amount of vitreous removed per infusate volume, per BSS volume. That is totally a function of technique, has nothing to do with duty cycle or dual port cutters or cutting rates or the diameter of the cutter, with all respect to the hydropoceal law that says that the fluidic resistance is proportional to the fourth power of the diameter. So let me repeat. The idea that, oh, well, this is a dense hemorrhage, we want a 23 gauge cutter because it has more flow efficiency. Nonsense, complete nonsense. Take the port to the vitreous. Don't draw the vitreous to the port. This is exactly the opposite of what's done in PHACO. In PHACO, the whole point with cortical cleaving hydrodissection, hydrodelineation, cracking, chopping, pre-chopping, and rotation, divide and conquer, all of these methods are very appropriate to protect capsule, to mobilize lens material. I've watched McCool and Sione, personally, two of the best cataract surgeons on the planet. The phaco tip hardly moves. It stays in the middle of the capsular bag and the lens material is mobilized to it. perfect for cataract surgery, exactly the opposite of what you want to do in retina. So when I've heard people say, well, I like 23 gauge, there's greater flow efficiency, you're not doing it right. Take the port to the vitreous. 25 and 27 work just fine in traction detachment and vitreous hemorrhage cases, and are in fact advantageous. Why? For one, as there's dense epiretinal membranes in the port, and it has what I call SED, sudden elastic deformation, virtually analogous to an occlusion break in phaco. That surge that happens is limited when you have a small diameter, just as it is in phaco. High cutting rates also reduce this high frequency pulsatile vitreoretinal traction. So if it's a long chain of little pulses of fluid that go through the port, little sips, if you will, instead of big gulps, you simply don't jerk on the retina. You don't have pulsatile vitreoretinal traction of this great an amplitude. So high cutting rates are always better. So when I hear people say, oh, well, no, you should use 3D or dual linear, use low cutting rates during the core vitrectomy, completely wrong. You use the high cutting rate for all tasks in all cases, absolutely essential. I reported with Stanley Chang and Brooks McEwen some years ago using laser for hemostasis. It's better. How did I discover that? By making mistakes. I did many, many diabetic traction attachments. I used diathermy to suppress bleeding, and as many of us still do, many people still do. And then I would see the 3-month post-op, and the retina would look great. 6-month, 1 year post-op, large atrophic holes, so-called ischemic, so-called atrophic holes, round holes in the posterior pole. And I look back at the 3-week picture, it wasn't there. So it wasn't iatrogenic in the sense of mechanically induced at the time of surgery. And I'm like, what is going on? I finally reviewed all the op notes. In every instance, it's where I treated with diathermy. So there's, if you will, not immediately apparent damage to the retina that results in necrosis down the road if you use diathermy. Diathermy is not smart. It cooks everything within a spherical pattern at the tip with its radiofrequency energy. Whereas if you use a 532 nanometer, in other words, green laser, as almost all of us use, you should never use a near infrared, a red laser. Always use a green laser, 532 nanometers, and that's ideal for absorption in the blood column. So if you treat vessels, even bleeding overlying the arcades, even bleeding just above the disc, you can do that with very carefully and avoid damaging the major arterioles, avoid damaging the disc. So I strongly prefer laser for hemostasis. Those who believe laser can only be absorbed in the pigment epithelium just don't get it. It absorbs perfectly well in the hemoglobin blood column. What better to absorb green light than red blood? So if you will, direct the laser energy toward a vessel, then the vessel, you have to use, don't use these 20, 30 millisecond pulses we use in the office. You got to use continuous laser, so otherwise you'll just get a spasm and it'll open right back up. Use this for hemostasis, far better than diathermy. A major point that I've been emphasizing for years now, but it's shocking to me that almost everybody still uses diathermy. Let's skip over that. So what about using the cutter for everything? So-called cutter delamination. There are 2 specific types. And I coined these names. One is fold back delamination. That, while safe, and people normally show it in their videos, see how easy you can use the cutter. They'll say, see, I can do all my diabetics with the cutter. Yeah, you can do easy cases that way, but not hard cases, not tabletops. And so fold back delamination works when the membrane is flexible and thin, and the advantage of it is there's membrane between the cutter port and the retina. What about conformal delamination? That's what you must do if the membrane's rigid and won't fold back. In this case, you must apply the port, not direct the port toward you, not upwards, but feed it in like you're eating a sandwich. You don't suck the membrane into the port, and you don't push it into the port. You slowly advance it like you would pushing wood into a table saw or a lawnmower over the grass. So it's feeding it in at the proper feed rate, and precise positioning of the port relative to the membrane is important. Why did I coin the term conformal? To indicate you must rotate the cutter around its long axis to make sure there's a bit of an up tilt so the port is not directed toward retina. Very important. So this is conformal cutter delamination. You're on the edge of the membrane. And I want to thank Byron Wood in our office for doing all these wonderful graphics that are in my book. And so here you're you're not protected. The membrane is not between the port and the retina. So this is what you must do if it's rigid. On the other hand, if it's flexible like this, it will fold back into the port, and now you got membrane between you. And so this is the best way to do it if you can do it. So you position just behind the leading cut edge so it will fold up into the port as depicted here. When do you need scissors? Anytime the epiretinal membrane is adherent to the macula, broad zones of adherence, customarily called tabletop traction attachments, very dense membrane with marked adherence to thin atrophic retina, particularly the mid-peripheral retina, particularly retina that's very ischemic, white vessels, retina that's been PRP'd with intensely before, or chronic TRDs where there's more atrophy. So thin retina with densely adherent membrane. If you try to delaminate, if you try to do that with a cutter, you're likely to make retinal breaks. So sometimes you just segment that if it's not elevating the macula, but in other instances, you will delaminate. What scissors should you use? When I first invented segmentation, I used so-called vertical scissors, as depicted on the left side of this slide. When I invented delamination, I used so-called horizontal scissors, actually 135 degrees. But once Grishaber was able to make these wonderful curved scissors, I used curved scissors for both segmentation and delamination. Numerous people don't get that. They say, oh, no, for segmentation, you got to use vertical scissors, and for delamination, you got to use the horizontal scissors. Mistake. Curved scissors are better. Why? What's the shape of the posterior wall of the eye? Curved toward you. Well, curved scissors are less likely to impale the scissors port in the retina. But this slide depicts another reason. Blade width is greater than blade thickness. The distance between membrane and retina is basically a potential space. So there's this big gap that you're going to introduce something in. So if you got something thinner to introduce in the gap, namely the thickness of a curved scissor blade, it's better. And there's another reason. In most cases, you're doing access segmentation followed by delamination. So you wouldn't want to use two pairs of scissors. One is more expensive, and you got to do tool exchange. So if you're doing access segmentation, you simply rotate your hand slightly along the axis of the tool, and now you've converted a segmentation device into a delamination device. Very useful. So this lists, again, the reasons you should use curved scissors rather than vertical or horizontal. If you do 27 gauge surgery, curved scissors won't fit through it. The vertical scissors from Alcon Grishaber actually work quite well as depicted here. So I again emphasize the use of curved scissors for both delamination and segmentation if you're a 25 gauge surgeon, or use of these straight scissors depicted here if you're a 27 gauge surgeon. What's the role of segmentation today? The primary role is access to the delamination plane. So I call it access segmentation. Typically, you should proceed in an inside-out direction from the optic nerve outwards along the temporal arcades. Develop the plane so you can find it. Don't use picks and peeling to do that. Use scissors to do that. Once you eliminate the adherence of this block of epiretinal membrane to the optic nerve, you can proceed outward as depicted here. But again, if there's dense membrane overlying thin atrophic retina in these post-PRP ischemic chronic scenarios, you can use access segmentation, simply use segmentation and don't follow with delamination. If you've had excessive bleeding scenarios, glial recurrence, reproliferation in the other eye, sometimes a few cuts with segmentation is enough and leave much of the epiretinal membrane behind. This depicts access segmentation. We're not finishing at this point. This just allows us to rotate the scissors and proceed with delamination. Should you put the scissors in wide open and close them? No, you'll tear these little attachment points, tear the retina. The retina is 1/100th the tensile strength of the membrane on average. If you put the scissors in closed and open them, sort of blunt dissection techniques used in general surgery, again, you tear at these attachment points. So you should introduce the scissors almost closed and cut right at the tips. Remember, scissors cut at a point, not on a line, and that point moves outward as the scissors blades close. So move it forward, almost close it, and cut right near the tip. Don't do this spreading phenomenon which causes retinal breaks as depicted here. Use this technique of having it almost closed and moving the scissors from side to side, searching for these little attachment points. You don't need to use bimanual surgery and tug on this membrane as many people do. It creates many iatrogenic retinal breaks. I'm not a big fan of bimanual surgery. Very few people do it well. What direction should the delamination proceed? Inside out. The central retina is thicker, more redundant. The membrane's thicker, more visible at that point, and you can devascularize the whole plate of membrane by detaching vessels from the disc. So many reasons to move inside out in most cases, typically on the temporal side of the optic nerve. This depicts inside out delamination. There's been a little access segmentation cut preceding sort of the 12 o'clock in this picture, and now we're taking these curved scissors and delaminating outwards to eliminate these little attachment points between membrane and retina. Once you've done that, you can then remove the posterior vitreous cortex. Notice that there was not a PVD created in this case. The delamination preceded removal of the posterior vitreous cortex, which is always in continuum with this plate of epiretinal membrane. So this idea of delamination before vitreous cortex truncation is an important one. So when do you do that? If there's no PVD or minimal PVD, don't just pull until you make one and cause retinal breaks. Simply start at the optic nerve head and delaminate outwards, and then you'll see that the outer edge of dense epiretinal membrane is always contiguous with the posterior vitreous cortex. So it'll be very easy to see this, and this is a far better way to proceed. This whole notion of en bloc is annoying to me, quite honestly. How did this come about? I reported delamination first. I reported this inside-out orientation. Others renamed it en bloc, published it, and said the point is to go outside in and use the vitreous to pull on the membrane and lift it. That is a guaranteed way to make peripheral retinal breaks. That is absolutely inappropriate. But even the term en bloc, what does it mean? In one piece. Highly appropriate for cancer surgery, absolutely inappropriate for vitreoretinal traction attachment repair. Why? It makes no sense to remove it in one piece. Well, they say, that's not what I meant. Well, don't use that name then. What should you do? Delaminate inside out and segment it into some pieces. Why? You can't look at everything at the same time. You're focused on the scissors, and when you're delaminating, say on the supratemporal vessels, you're going to have a little push out force in the scissors, and you can inadvertently be applying traction to the infratemporal vessels or to the nasal retina or to the periphery. And so if you try to move it in one big piece, which is what an en bloc should imply from a semantic perspective, that's a mistake. Simply don't do that. So delaminate inside out, but cut it into some pieces. Far safer, far better. What about bimanual surgery? Sounds like a good idea, but we always use two hands. So let's talk about what instruments will be, and if you believe yourself to be a bimanual surgeon. I always use two hands, but I don't call myself a bimanual surgeon. One, if you have scissors in one hand and forceps in the other, and you're dexterous, and you want to hold the membrane still so you can carefully delaminate, I get it. You got to have a chandelier. That's a good idea. But if you have a pick in one hand and a cutter in the other hand, which some people call bimanual surgery, that implies you're a peeler. And if you peel in diabetic traction attachments, you make retinal breaks. If you have a forceps in one hand and a cutter in the other hand, it's okay. But again, scissors in one hand for the difficult cases and forceps in the other are the best combination, the safest, so that you don't make inadvertent breaks by inadvertently lifting to expose the plane. You don't need to see up underneath the membrane. It will elastically scroll up on its own as you cut. Chandelier illumination frees up the endoilluminator, but it doesn't provide as good illumination as the endoilluminator because it's not focal and it's not retro and it's not specular, it's broad. So what are the disadvantages? Shadowing and glare with fluid air exchange. Of course, you got to make a fourth wound. If you're going to do forceps plus scissors bimanual surgery for certain difficult cases, then you must use the chandelier. The Alcon one is advantageous because it has a malleable shaft that positions it for you, and you can use a trocar candle to place it so that you take the same quality of wound construction there to prevent vitreous wick and leakage as you do for your other three wounds. I don't use peeling at all in diabetic traction attachments. I don't know why people start with this exercise. It's like starting to do an intercap and converting to phaco. Makes no sense to me, but I don't get it. Now, if you have macular distortion, once epiretinal membrane along the arcades has been delaminated, okay, ILM peeling is just fine, and that should be done with forceps, not with picks, tissue manipulators, and spatulas. So how should we do hemostasis? As I told you, the laser seems to be a better way to do it because it limits damage to the vessels. And that's the end of the presentation. There's one point that I should have put in here that occurred to me operating yesterday with our fellow. When you do a diabetic vitreous hemorrhage, there's a tendency, of course, to pay most attention to NVD, disc, neovascularization of the disc, and as well as posteriorly. But in fact, you should pay attention to the periphery as well. Why? There's often little tufts of neovascularization, so-called NVE, even at the equator, that'll be adherent to the posterior vitreous cortex. If you don't carefully remove traction of those, post-op hemorrhages can be caused by this so-called skirt of remaining peripheral vitreous tugging on these sites when the patient has a saccade, typically when sleeping and the blood pressure is higher, and they'll get a bleed. So I think that's an important thing to think about. Glad to answer any questions. Let me look here and see if there's some that are up. Okay, so I was asked about what's the technique for complete hyaloid removal in diabetic retinopathy surgery. I've actually just described it, but the point isn't complete removal. So for example, if you got a traction attachment, peripheral vitreous shaving is completely inappropriate. It's a ritualistic behavior people use, absolutely necessary in giant breaks and PBR and regmatized detachment, but in posterior pole disease, macular surgery, and moderate-sized traction attachments, peripheral vitreous shaving has no role. Don't do it. Don't make aggressive PVDs. I've said this over and over and over again. If there's vitreomacular traction or a traction attachment, truncate and then resect outwards toward the skirt, not emphasizing peripheral vitreous shaving, which, as I said, is overdone. I think it's a very, very important thing. So recurrence is about tissue damage. It's not about leaving tissue behind. With the exception of the point I made, if you leave epicenters and they bleed from their cut edges, then a fibrin bridge will occur and gliosis can occur across that fibrin bridge. That's an important thing. With respect to bleeding, how do I control it? If I don't do pre-coagulation, so I don't take the diathermy and cook everything that's red like so many people do, because it causes retinal necrosis and increases the likelihood of retinal breaks, even intraoperatively. So what do? I delaminate. If I encounter a bleeder, I immediately raise the intraocular pressure with the foot pedal to stop the bleed. I then take the laser and introduce it, and the valve cannulas are nice because the pressure doesn't drop when you change tools, and then I'll laser that area, and it works quite well. Let me zoom down and see if there's some other questions here useful. I was asked a question about complete vitrectomy. I think I've already addressed that. Let's address something else. There was a question about reoperation. You do a diabetic vitrectomy, you do everything you can to achieve hemostasis, you get a good result surgically in the first post-op day or a day or 2 or 3 later, they bleed. What do you do then? What you should do then is to first do an ultrasound to make sure there's no detachment. If there's no detachment and there's no iris neovascularization, wait. How do I handle this? I talk to the patient, and I say, first you got to know what the vision is in the other eye. If the vision's good in the other eye, waiting's appropriate. If the vision's bad in the other eye and the patient feels up to it, you might want to reoperate relatively soon. If the blood is very dense, you're much more likely to have to reoperate than if it's quite liquid and not so dense. So I tell the patient, this is a common occurrence. We've dissected scar tissue that has blood vessels in it. You can't coagulate everything safely. So don't worry, the blood's not going to damage your eye. Now, if it's driving you crazy, we can remove it in a couple, 2, 3, 4 weeks. But on the other hand, if it's not driving you crazy and you got good vision in the other eye, we'll monitor you with ultrasound, and we can wait a month or 2 or 3. So I'll tell the patient, why don't you pick a time you're comfortable with? I know it's not fun to be reoperated, and I know it's not fun to have blood blocking your vision. So why don't you pick a time, maybe about a month or so? What do you think? And they'll say, yeah, I'll come back and see you in a month. It seems to be getting a little better every day. So that's the kind of discussion you'll have typically at the 3-week visit. What are my laser parameters? Always use continuous laser for retinal breaks and for hemostasis. I actually... when we do PRP, I don't like the repeat mode because there's a tendency to walk it through the macula if you're not paying attention, and I don't want to treat over an area of prior treatment with laser. So there's a tendency to just make these tidy little rows and laser on top of prior laser marks if you do repeat mode. So I push the pedal individually for each spot. Let's see here. Any more questions? So this is asking about laser versus anti-VEGF agents. The Diabetic Retinopathy DRCR network, the Diabetic Retinopathy Clinical Research Network, drcr.net, has made this very clear. It's absolutely clear that anti-VEGF compounds are more effective than laser or steroids. I don't use, so if the patient, if you believe truly in your heart this is a one-time visit to your office and they've got neovascularization or they got microaneurysms, leakage, or macular edema, and treat them with anti-VEGF compounds and laser. I used to tell the residents, knock it down with Avastin, keep it down with laser. But if you think the patient's going to be able to come back in a month and again, then use anti-VEGF compounds in lieu of laser. Laser works. But when I hear these people touting ultra-wide field angiography, which is ridiculous, to find the peripheral ischemic areas to do targeted photocoagulation, it is utter nonsense. It's been disproven as a thesis. But clinically, here's what happens. In my office, I've been doing this a long time, numerous patients with very, very dense PRPs, 3 or 4 sessions of PRP, almost a wall-to-wall PRP. They come in our office, it looks stable on indirect ophthalmoscopy or maybe the 90 diopter lens, and you get an OCT and there's macular edema. Well, where were you going to laser? If you take that same patient and treat him with anti-VEGF compounds, and Eylea is better than Lucentis, which is better than Avastin, it's diabetic macular edema goes away. So what role does this ultra-wide field peripheral angiography finding targeted ischemia have? None, in my opinion. Massively overdone as a notion. The question is asked, should I leave air in the end of the eye or leave gas? We always think that the idea that air would retard bleeding, I'm not so sure. There's a paper, I don't have the reference in my head, but that concluded that air did not produce less. I'm also asked about silicone oil. I try not to use silicone oil in these cases for the reasons I've already illustrated. If you must use it, I often don't do any retinopexy, and I use it for what I call regnomatogenous confinement and retinopexy avoidance. That's a major advantage, actually, of oil, that you don't need to do laser. So I see these people put in laser, put in oil, and then they laser all over everywhere, and they've created a tremendous amount of reproliferation just from the laser-induced damage. So I largely use laser in very difficult cases that I'm likely, use oil in very difficult cases I'm likely not ever to be able to remove the oil. And then I'm also asked here about double staining. I don't use that terminology, but let's address staining. In the diabetic traction attachment case, I rarely stain. If there's obviously sort of corrugation or folds to the macula, then I use brilliant blue to stain for that. Kenalog or triamcinolone or triasis is not a stain. It's a particulate marker. I don't find it necessary, but I use focal illumination with an illuminator, not a chandelier. If you use a chandelier, you can't see the vitreous. If you use Ingenuity, you can see clear vitreous better. But if you use the light reflected off the vitreous cutter in a focal illumination and retro illumination manner, focal like a slit lamp beam and retro by bouncing it off the vitreous cutter, you can see the vitreous without having to introduce this additional variable and cost and risk factor of putting triamcinolone in the eye. So I don't do that. I think that's all the time we have, so I want to thank everybody for listening and hope this was useful to everyone. And please participate at Orbis going forward. It's a wonderful organization. I want to thank Orbis for making this possible. Thank you.
Thank you, Dr. Charles.
You're welcome.